Giuseppe, you think we should start now?
I'm ready anytime. So I
Okay,
think it's
Yes, sir.
जगरूप शुरू
Yes,
करवाओ,
sir.
फिर
Okay,
मेरे
sir.
को मेरे को बुलाओ, फिर मैं शुरू करूंगा.
Okay. So we welcome you all for this webinar on cerebral AVM tips and tricks. Now I would like to invite Professor Atul Goel, who did not require more introduction. Not only in India, he's worldwide well-known figure, well-known academician, and a wonderful surgeon. So, sir, welcome to you, sir, and over to you, sir, please.
Okay, Jagrup, thank you very much. Thank you to Intas for organizing this beautiful show. More important is that I have been able to invite my very close and very dear friend, Professor Giuseppe Lanzino. Just to introduce Dr. Lanzino, particularly to the young people of our country, I have to tell you that Giuseppe is one of the most stimulating and fantastic. He can stimulate a stone and into give life to that person. So if you want to become a real good neurosurgeon, if you want to be an academic neurosurgeon, you have to spend few days with him, and he will stimulate you, and he will encourage you, and he will see to it that you start writing papers, you start thinking, you start learning, you start enjoying, you start meditating, and you start living neurosurgery. You live neurosurgery with Giuseppe. So I had a great opportunity 32, 33 years ago to spend one full year with Giuseppe, and we stayed together, we lived together, we worked together. He was a very young boy at that time. He was looking for opportunities in US. We were together in Pittsburgh. And despite the fact that he was just a medical student, he stimulated me to that extent that I started writing papers, working on various projects. And believe me, from that point started my academic life. And today I have got 700 articles, next only to Giuseppe. Giuseppe is a prolific, not only writer, but a student and a scientific meditator of the subject of neurosurgery. He worked in Pittsburgh for some time, then went over to Virginia where John Jane, Edward Laws, and people of that caliber were there, and he did his residency in neurosurgery with these people. And he was associated with John Jane, the editor of Journal of Neurosurgery, for a period of time. And John Jane was talking to me once, and he considered Giuseppe as his son. That was a big honor from a big man, John Jane, at that time. And Edward Laws, as you all know, he was one of the very big pioneers, and he is a pioneer on pituitary tumors and various other things. He was World Federation president, and he's a professor now. I think he's in Boston. Then Giuseppe moved on with, spent 1 year, 1 or 2 years with Bob Spetzler at that time in Barrow. And from Barrow, he went and he learned microneurosurgery, the techniques of vascular neurosurgery, techniques of aneurysmal surgery, AVM surgery, and things like that. And then he went over to Buffalo, where he learned endovascular neurosurgery, endovascular, interventional radiological procedures. So now we have a very fantastic situation where the presenter is not only a big name in vascular surgery, but also in vascular interventional neuroradiological surgery. So we have a person who has, you will be surprised, and I want young neurosurgeons to listen to what I'm saying. I was just going through his CV today morning. In the year 2020, he has already got 62 publications on PubMed. And that 62 is in big journals and reputed journals and the topmost journals. So it is by no mean a small contribution in not even 9 months. So that is the level of involvement of Giuseppe in the subject of neurosurgery. He's a fantastic, and you will hear. I will talk more about him once we hear from him. So today, what he's going to show us, he's showing us about AVMs. He's going to talk on AVMs, and as you know, AVM forms one of my very favorite subjects. AVM surgery is my absolute heartthrob. I love neurosurgery, but AVM is the one which gives me quite a bit of stimulation. So if possible, I will interrupt Giuseppe and keep asking him questions. So he will talk on AVM surgery and the role of embolization in AVM treatment and several other tips and tricks he will discuss with us. So over to you, Giuseppe. Let's begin with fantastic hug to you, to my dear friend, to my dear brother, Giuseppe Lanzino, for you, my dear friends.
Hey, thank you. Thank you, Atul, for the very generous introduction, and welcome to the colleagues that are connected from all over the world. In this presentation, what I will do, I will discuss some and illustrate some of the tricks that I have learned over the years. And the presentation is particularly geared toward the younger colleagues. A lot of the things that I will discuss are those things that I wish my mentors would have stressed more during my training, and are also those things that often you don't find adequately discussed in the textbooks, but yet they are critical parts of the conduct, especially of the operation, as well as the decision making. Dr. Goel was very biased in his introduction. As you can see here, young Dr. Goel with me and two dear friends, Spiro Pomones from Greece and Mark Kalinsky. And here it was Christmas in Pittsburgh 30 years ago. So we have been friends for a long time. Now, when we think of AVMs, and of course, a lot of these considerations apply primarily to complex AVMs. It's a fascinating topic because there are a lot of components that are critical for the success of the treatment strategy. There is a very strong psychological component, and we'll touch upon that, and then the planning and the strategy. And then, of course, there is the execution. So it's definitely one of those procedures that it's really at the pinnacle of neurosurgery, and that really requires all the different components that make our specialty so fascinating. Well, when you're going to operate on a complex AVM, first of all, you need to be ready that day for a fight. So you must be psychologically prepared and never underestimate in AVM. Charlie Drake, one of the giants in our field, is quoted to have said, AVMs are nothing but hard work. And there is a lot of truth to that expression, because definitely in the execution of the AVM surgery, it's painstaking, hard work, focus, concentration, and ability to fight and to face any surprise that you might encounter. Now, as I said, this is about basic tips and tricks, and especially for our younger colleagues. We are living in an era where, rightly so, there is a lot of stress on minimal invasive procedures. There is a lot of stress in minimizing the side of our exposure. But I still strongly believe that when we deal with complex large AVM, similarly to large meningiomas, adequate exposure is very important, because you might be facing, you need to have a vision of not only the lesion, but the surrounding structures. And also you need to be ready to be faced with brain swelling or intraoperative hemorrhage. So you don't want to confine yourself to particular corners. One other reason why for an AVM it's important to have an adequate craniotomy and adequate exposure is because it will allow at the end, you see there is a prominent main draining vein, but in a large AVMs there are often also several secondary draining veins, and that's important to have adequate exposure of those, because at the end of the procedure you can do an ICG fluorescent, and sometimes if you have left a small shunt, a small nidus, you might see early opacification of these secondary veins that you might miss if they're not adequately exposed. Then, of course, it's very important, as we will see, complex AVMs usually come to the surface, and it is very important to have an adequate exposure as of the gyri and the sulci surrounding the AVM, as superficial AVMs going deep are primarily a sulcal disease. Now, it's important to be careful from the very beginning, and the dura opening is actually critical in a patient with an AVM, because as you can see, especially in patients who have suffered a prior bleed, there is often some degree of dura neoangiogenesis. There are arachnoidal bands tethering some of the veins to the dura. There is support from the dura, and you don't want to be in a position where you start AVM surgery and you already have a subarachnoid hemorrhage from bleeding from these superficial feeders, or from tearing a structure because of arachnoid bands tethering the dura. And as the early subarachnoid hemorrhage can compromise adequate visualization of the lesion. ICG fluorescent is a nice tool. It's not necessary, but definitely once you are there, it gives you a further confirmation in identifying very early on the main feeders and confirming the draining vein. The way I look at ICG fluorescent for AVM surgery, it's like the way I look at a lot of technology that we have available. Might not be absolutely necessary, but if available, it's always better to have as many aids as possible, just to confirm what you already know from looking at the angiogram or from the visual inspection. And ICG fluorescent, of course, it allows you to see what the microscope sees. And in superficial AVMs, I found it fairly helpful in inspecting the cavity and the surrounding brain at the end of the procedure, to further confirm the intraoperative impression that indeed the the AVM has completely been resolved. But we know very well about the limits of ICG fluorescence in assess for the intraoperative assessment of um, residual AVMs, or they could be residual that is deep, not visualized by the microscope, and therefore it's not necessary, it's not the only tool. Now, the one of the key aspects of AVM surgery, and that represents the one of the most difficult part of the procedures, as far as I'm concerned, is that usually AVMs are not like this nice drawing, perfectly conic with the superficial component where you can get around, but quite often the AVM it's hidden underneath normal brain. It's almost like it develops and extends almost like an iceberg. And really one of the key aspects of AVM surgery is to carefully develop that plane between the so-called nidus and the surrounding brain. And that can be quite challenging as the AVM, the hidden part of the AVM digs underneath normal brain, because of course you try to compromise, you try to stay as much as possible along the border of the AVM, but the border of the AVM, especially as you deal with complex AVMs, is rarely perfectly spheric in geometry. So there are small portions of nidus that tend to deep underneath the brain, and to find that perfect compromise between not or minimizing brain manipulation and staying on the borders of the nidus can definitely be one of the challenging part of the procedures, and even for the experienced surgeon can be difficult at times not to enter the boundaries of the nidus. And of course, this becomes even more challenging when you are dealing with AVMs in eloquent areas, because in non-eloquent areas, anterior right frontal cortex, you can sometimes cheat in doubt and stay on the brain side. So this is really, I found, one of the key things, and one of the main challenging is to how to deal with the part of the nidus that digs under normal brain almost as an iceberg. So one of the key aspects of the procedure is at the beginning. It's important to widely open the sulci and the arachnoid around the AVM boundaries in order to really open those sulci around the AVMs like a book, so that you can more easily look in the depth and be able to expose those portions. As I mentioned before, this is also a nice part of the operation where the planes are intact. You're working under the microscope. And I found it psychologically also very useful, again, from a psychological point of view, because it's a beautiful dissection as you really open those planes under high magnification with microscope, and you start nidus and the draining vein. So psychologically, as I said, it helps because it makes you feel good about the overall procedure and how things are going at that time. Now, it's important to open the arachnoid all around, as I said, and to really release those sulci so you can get exposure um, of the uh, uh, of the depth of the sulci and try to get a idea about the true extent of the AVM. And that dissection is facilitated by the fact that the veins are arterialized. So as you can see, they have a certain tendency. And the surrounding arachnoid, it's often thickened, especially in patients who have suffered prior bleeds. And that makes the initial dissection easier. And as I said, this is as Mike Lawton in his book eloquently described this phase of the operation is this so-called calm before the clash. As I said, the psychological is very important because you start feeling good about the so as you approach the difficult and critical part of the surgery, you are in a good psychological, positive psychological state. And also the key importance is that this preparation, this homework will open the planes, minimize brain manipulation, and also facilitate dissection around the nidus. Atul, do you have any comment about these initial aspects of the surgery? Or?
Yes.
I think.
Yeah, Giuseppe.
Yes.
Just a minute. Can you hear me? Wait. Sorry.
Yes, we can hear you.
No, you are absolutely correct that we have to have a very strong preparation. We have to not only, we have to see the angiography, we have to see the investigation, we have to know exactly the location of the AVM, we have to know exactly where the feeders are coming from, we have to know exactly which artery has to be first taken, which artery has to be next taken. We have to exactly know before operation. All these things, you see, our preparation. One is you can be calm and you can be comfortable only if you have prepared and spent the whole night studying about the AVM. This clash, as you have mentioned in your slide, this clash is with a very big tiger. And if you have to prepare you have to strengthen your muscles much before you enter into to the operation theater. Do you agree, Giuseppe, what I'm saying?
Yes. I think it's a very important phase for a variety of reasons. And again, when you're dealing with the complex AVM, the psychological aspects are very important. So also for me, psychologically, having identified all the main feeders, and we can discuss whether or not you should occlude the feeders early on, or you can keep working around the AVM and so forth. But I think having identified also the main feeders and having everything exposed, then you are ready that if you get into problems, it's easier to act and proceed accordingly. Now, as I said, at the beginning of the resection, it's a beautiful arachnoid dissection, and you might feel you are doing very well and you are the best neurosurgeon in the world. But if often toward the end of the procedure, that feeling it's often gone, and you might deal with something like this. So it's really a type of surgery that is challenging, and as I said, really summarize some of the key aspects that are required in our profession. But usually at the end of the day, it's also very, very humbling. But likely in the majority of cases, you are able to face all these different issues, and patients do quite well if the strategy, the planning and the execution has followed the basic principle. Now, this is another issue that it's important for younger colleagues to realize, that during the resection of complex AVMs, you might be faced a few times with a bleeding that at the beginning is difficult to control. I never forget that one of the very first AVMs that I was operating, I was faced with the challenging bleeding, and I called in the operating room my chairman at that time. I was at the University of Illinois in Peoria, Dr. Elwood. He came in, did not scrub, and he said a few words that really have stayed with me and have helped me a lot of times in similar situations. He basically said, when you're working with the complex AVM, you might be faced with the bleeding that is difficult to control. But remember that usually that you are able to eventually to control that bleeding. And when it happens, remember, it can be challenging. You might get discouraged as you are facing it, but usually you have been able to control and you have done it before. So that's something that, again, one of those psychological elements has been very helpful for me when I'm faced with that bleeding and you are getting a little bit impatient and nothing seems to work. Just remember that you've faced it before, and usually it can be eventually can be controlled.
Giuseppe, can I make a small comment here?
Absolutely. Go ahead.
See, it is very crucial and absolutely important also to know, that where experience counts, you have to have that experience, you have to have that kind of understanding that this AVM is resectable and you will be able to control the bleeding. You cannot decide this that you are not able to control during the operation. That preparation has to be done before operation. And you have to realize that yes, it is possible, and no, it is not possible. I think that decision is absolutely critical. What do you think, Giuseppe, about that?
Yeah, no, it's again, as I say, it's part of that preparation where once you decide to do it, you need to be ready for a fight. And when you go into a fight, you need to strongly believe that you're going to win. You have done it before, and that gets you into the correct mindset so that during the surgery, because the problems usually tends to happen toward the last part of the operation when you are tired, and therefore to have that mindset that you were prepared for it is definitely very helpful, because you're not unprepared. Now, here again, to stress what is one of the main issues, as far as I'm concerned, is that the part of the nidus that is like an iceberg hidden underneath normal brain, and it's critical, it's very important to, of course, to stay outside the nidus, because that's one of the most common mistakes that if you try, of course, to stay right along the nidus of the AVM, but the nidus digs underneath normal brain. And of course, as you try to avoid as much as possible manipulation of the normal brain, you might end up without realizing at first, you might end up going into the boundaries of the normal nidus, and that can be quite a difficult mistakes to correct, and also can be potentially dangerous, because the residual portion of the nidus that you might have left under a lip of brain can start bleeding, and sometimes the bleeding it's not into the cavity, but it's internally, and you might end up with an intraparenchymal hematoma. And we'll discuss about that in one of the next slides. Well, this is another critical aspects is that there are those deep feeders that are at the bottom of the AVMs that, as we all know, are difficult to isolate. And it's important when dealing with these feeders, first of all, before attempting any coagulation, it's important to isolate an adequate length of these deep feeders, because the last thing you want that they retract, they start bleeding, they retract into the parenchyma, and then you can have a bleeding that is difficult to control, and also a bleeding vessel into normal brain. These deep feeders, and I will show, I will illustrate in example, they are abnormal vessels. They lack a muscle layer, and therefore they respond very poorly to normal bipolar coagulation. While these feeders, they better respond if there is a situation where the flow through the feeder has been arrested, and I will show an example of what I mean by that. And then there is this dirty coagulation that has been popularized by Ernest Niemi. And basically, since the feeder itself the deep feeder does not respond to normal coagulation, the idea is that if you coagulate and you have a very thin layer of parenchyma in between the bipolar blades in the thin vessel, then looks like that it's a little bit easier to control these feeders. Now, this is situation where you see, like as you go toward the deep of the AVM, now at the bottom you see this deep feeder. So number one rule, important to have enough length. Try to coagulate close to the AVM, and you can see first attempt with the bipolar, it's like you have not even touched it. Further attempt, same thing. Really, normal coagulation really doesn't work very well. So as I said, the trick is to have one of those micro AVM clips that you can put. So now you have a situation of flow arrest into the feeder. And you can see as you try to coagulate, it will rupture, but the blood is coming, it's retrograde from the AVM. There is no antegrade bleeding through the feeder, and that's one way that you can control that bleeding. Now, I found those clips very useful, but I try to avoiding using them as much as possible, because I don't like to have the bottom of the field filled with the clips they can get on the way as you proceed with your dissection. This is another situation, another feeder. Here is two tricks. Number one, as I said, make sure that you leave enough, you have isolated enough length. And number two, coagulate on the AVM side and leave a tail so that the deep feeder doesn't retract into the normal vein. And number three, I've learned this from Bennett Stein, when you cut the feeder, don't cut it all the way across. At first, you cut about a third of 2/3, so that if there is additional bleeding, and there is still some, you can see exactly right here what I mean. There is still in continuity, so you don't give it chance to retract, and then you can finish it with additional coagulation. So A few little practical things that you might not find in the book, but again, they are very useful when you are faced with this type of situation. You can see always cut close to the AVM, leaving a tail that is long enough. Here in this case, another situation that I like to illustrate, some of AVMs have, you can see here, this is a direct AV shunt. It's a very large arterial feeder dumping directly into a vein. So you can find this in some high flow AVMs, and of course, taking these feeders as it empties into the main vein, it's a major step in the further advancement of this particular procedure. Atul, do you have any comment about how to manage these deep feeders?
You know, as you rightly said, Giuseppe, these deep feeders, there are three types of feeders. One is large vessel, one is medium-sized vessel, and one is the deep or small feeders. So these are completely different. You see, large vessels can be relatively easier to handle. Small vessels are difficult to handle. You see, my understanding about AVM surgery is if you know small vessels, if you understand small vessels, you can do AVM surgery. If you do not understand small vessels, you will not be able to do AVM surgery. Now you will ask me, what is that understanding? You see, the small vessels actually lead to the big vessels. So that trick has to be understood and has to be learned, that small vessels actually have to be followed. They cannot, you can try coagulation here and there, but unless you follow and get to the major mother feeder, it is difficult to get that thing under control. Now, the other thing that I'm sure Giuseppe will touch on, see, sometimes what happens in AVMs is that it bleeds from this point, it bleeds from this point, and it may happen that it is bleeding from more than one or two or 3 points at the same time. And then you will have the trouble, and you will have to identify which one to handle, which one not to handle. You have to first handle your own self and then to the bleeding vessel and go further from this point to that point to that point. So it is, all the entire game is to identify the feeder and to get to the feeder. This is the game of AVM surgery. AVM surgery is nothing but get and hit and stop. That is AVM surgery. If it doesn't stop, then you have to struggle to stop it. Unless it stops, your efforts have to continue. That is what I have to say, Giuseppe.
Thanks. Very well said. So here is again to summarize some of these basic steps. Let's see, maybe. So open the dura very carefully under the microscope. There are often adhesions between the dura, arachnoid trabeculae, or feeders from the dura. Here I like to, a small secret, and that also for the young colleagues in neurosurgery, you learn from everybody. You learn from people that are well known, neurosurgeons that are well known. You learn a lot for surgeons that we might not have heard, but they have great techniques, very practical issues. And this is the sharpest instrument in the room, no matter where you go around the world. And it's the tip of a 1cc tuberculin syringe. I learned this from you, Ernest Niemi, and that's quite often what I use for my arachnoidal dissection. And it's the sharpest instrument in the room, and you can change it once it stops working. And you can see here, again, opening those planes. This is an interesting case because this patient had the prior radiosurgery. And the radiosurgery, it's a young lady. Radiosurgery works really well, especially in young people, but for whatever reason, she had a more diffuse type of AVM. She had not responded well to gamma knife. And despite that, she had the bleed, so we end up operating. But you can see, and this is, of course, has been observed by many others, after gamma knife, it is actually much easier to operate on an AVM. First of all, you can see the tissues are scarred from 2 prior bleeds. And what the gamma knife does, for whatever reason, the deep feeders are much easier to coagulate after gamma knife. And also the gamma knife, the radiation triggers some degree of gliosis of the surrounding brain, which facilitate the dissection of the nidus from the normal brain. So you can see here the steps that we discussed before: sharp opening of the arachnoidal planes, and this is really, and then circumferential dissection of the AVM, disconnection from the brain, coagulation of the incoming feeders. If there is a doubt, I like to put a temporary clip and see what happens to the AVM before making the decision to go ahead and sacrifice a vessel here, going down into the interhemispheric fissure. And again, you can see how the surrounding brain is gliotic from the effects of 2 prior bleeds and partially from the gamma knife. And there is no question that the dissection becomes much easier, even in very challenging AVMs. This particular AVM was smack in the frontal motor area. So again, the main purpose of this lecture is to focus on some basic principles that sometimes don't receive adequate attention in textbooks. And this is, you will find in Yassergil's book, which I highly recommend to anybody who's interested in AVM surgery. It's really where you find everything you need to know about the techniques and AVMs, despite the book was written in the mid 70s. But there is a statement, is that the secret of AVM surgery is the ventricle. And of course, you are reading a book and you come across this statement, and you don't realize the magnitude until you're experiencing that. Basically, I think what Yassergil was trying to say is that those AVMs that have a conic geometry and they go deep toward the ventricle, these deep feeders are much easier to coagulate if you gain access to the ventricle rather than you try to do it right at the interface between the deep portion of the AVM and the parenchyma. In other words, you go down, you find the ventricle, and then it's much easier to come across these feeders. Another consideration is that what I have observed is that when an AVM comes to the ependymal surface or even close to the ependymal surface, there is always a deep vein, even though you might not see that small deep vein on the angiogram, because on the angiogram you see that you see primarily the main draining system. But once the AVM gets close to the ventricular surface, there is always a small draining vein, a deep draining vein in that portion. This picture and this concept allows me also to discuss a relatively new principle that has been proposed by some colleagues. And the principle is that the AVM, it's a low pressure shunt. So the AVM is basically sucking blood from all the structures around it. if you approach the AVM the way we have been traditionally doing it, and you go circumferential, you identify the main feeders, and you start taking the main feeders, then you decrease blood supply from the main feeders. And what this theory suggests, you might actually increase, you might, suck even more blood from the deeper feeders. And that would be one of the reasons why some of these feeders are much more difficult to control, because we tend to deal with that at the end of the procedure, after the larger feeders have been taken. Those who support this theory suggest that one of the first steps of the surgery should be to go down at the bottom of the cone, identify these feeders early on before you take these feeders, because if you do early on, the amount of flow through these feeders is less, because the AVM flow is overwhelmed by the larger ones. So that's something that I think we will hear more and more, and there are already colleagues that have modified their technique accordingly, to go down to the depth of the cone first, deal with these feeders, and then deal with the rest of the AVM.
Giuseppe, just keep this slide. Just keep this slide. Go
Yes.
back. You see, it is so important to know that there are ventricular feeders. And ventricular feeders are, as has been said, that they are very high flow feeders, and almost 100% of large AVMs, you see, majority of large AVMs have a ventricular feeding connection. So we must know that whilst after, when we are coming and we are thinking that yes, AVM is being dissected, and at the end of the whole operation, there is a sudden huge gush of blood from these ventricular feeders, they can actually be very troublesome. And at that point, as Giuseppe has mentioned, that we have to open the ventricular cavity a little larger and get to these major feeders, so that, not at the tip of the cone, but inside the ventricle, you have to get those feeders. I think that is very important point.
Yeah. Now here I illustrate one of these situations that Professor Goel mentioned. This is a large anterior frontal AVM. And if you look at the angiogram, you don't really get the sense that there is any deep venous drainage to this AVM. It's in a favorable location. It's a little bit diffuse, but definitely favorable location. Excuse me. Sorry. So this is the postoperative angiogram, resected the AVM. Because of the location, I was able to cheat a little bit and stay on the brain side. So I was confident that everything had been resected. And you don't see very well in this lateral projection, but when you look carefully at the AP and look at this area, you see there is a tiny little bit of nidus fed by this deep feeder. And this is actually an early, you will see it's an early draining vein. And you can see this, and it's a very small residual nidus. So, but this is a small, deep vein, draining vein fed by this portion of nidus that is fed by this perforator. And you can see here on the postoperative MRI, it's very interesting because you see the resection cavity. You see still this early vein, but if you can see, the bottom of the AVM was here, but somehow there was still a very small portion of tiny little piece of nidus that, as I said, that's the most difficult part for me, is that digs like an iceberg into normal brain, and the boundaries of the nidus in complex AVM are never so sharp, and there are always these irregular components that go into normal vein. But you can see here it's a little bit unusual because there is a fair distance between the ependymal surface and the bottom of the AVM, and despite this, yet there was a small residual tiny little nidus with the early draining vein that was missed at surgery. Now, very important, again, we discuss and we all share experiences, but if you have not experienced yourself, if you don't have enough experience, sometimes you might miss the profound significance on what is said. Like Professor Goel in his last comment mentioned that you can remove the AVM, and then what happens, all of a sudden the brain changed consistency, and you say, what's going on? I see no bleeding, everything looks good. When that happens, you have to be immediately suspicious that you might have had a hidden hemorrhage. There can be intraventricular hemorrhage. So the first thing is to think about the ventricle, and doesn't take too long for a small bleeding to cast the ventricle and to create some massive brain swelling. Or other times you might have had, without realizing, you might have gone through the nidus, left a small portion of nidus hidden underneath the brain, and that portion of nidus might have bled and caused an intraparenchymal hematoma. So this is really one of the most terrifying parts of the procedure. When you're dealing with the complex AVM, all of a sudden you see that the brain changed consistency, and the experience tells you something is wrong, and it's usually intraventricular hemorrhage. The case you go to the ventricle and you can inspect, or could be intraparenchymal hematoma that it's hidden, and therefore in those cases bring the ultrasound to confirm. Now, likely, as we said, if the strategy and the executions are correct, and of course, it's always good to have a little bit of luck. Eventually, all these AVMs, at some point, they surrender. And when I always remember the words of my dear friend Evandro, who said, you know, like big meningiomas, at one point, you get one point of the operation where the AVM, suddenly you get the feeling the AVM surrenders. Like, you know, meningioma, you have the bulk, the meningioma internally, and then all of the sudden, almost the surrounding portion of the meningioma and the capsula, they infold almost spontaneously, and then you know that you are winning. The issue is that the AVMs are a bit different than meningiomas, and when that happens, and I'm getting that feeling, I think I got this one. It's gonna be a success. I always try again, you know, go back to that psychology. You don't want to be too confident about anything during this type of surgery, because then if you feel that the AVM has surrendered, then you have to deal with another bleed. Again, you might not be psychologically prepared. But again, to discuss candidly about the psychological aspects, it's always interesting for me, this internal fight where I can get the sense that the AVM must surrender, but at the same time, I try to tell myself, okay, don't get too confident. You know, don't know, it's not over. It's not over yet.
Okay, Giuseppe. Before
Yes.
you go further, let me. You will discuss about the role of embolization later, right? Because
I
Sabrish
will.
Natraj,
Yes, if there is time, I have some.
yes, because
some
Sabrish
slides.
Natarajan is asking whether we will discuss this later, and
Yes.
also Sabrish is asking whether if the AVM is ruptured, what is the time frame that you will like to operate? Whether you like to operate immediately or you like to wait, or what is your story?
Well, when an AVM is ruptured, of course, it all depends on the patient condition. I think that if you need to evacuate the hematoma, then I go ahead, evacuate the hematoma. In those circumstances, I do a CT angiogram. If the AVM is relatively easy, then I might remove the AVM at the same time. If the AVM is complex, then if possible, I try to avoid removing the AVM at the same time you are dealing with the life-threatening hematoma, and you have brain edema, and the boundaries of the AVMs are not very well defined. The other thing is to keep in mind is that when there has been a previous bleed, the nidus often can be split. So it becomes even more difficult to be able to define the nidus, even if you operate in a delayed fashion. If the patient, the hematoma is not life-threatening, I always prefer to wait as long as the angiogram does not show that there is obvious compromise of venous outflow. There are situations where the AVM, those are usually AVMs with the single draining vein, where you do the angiogram, you see that there is obvious compromise of venous outflow. There is relative stasis in the vein. Often there are varices. Those very few AVMs, but those are very dangerous because the risk of rebleeding is very high. For the majority of the other ruptured AVMs, I don't, and there is no reason to operate acutely. I think it's always better to wait a few weeks because then you have a liquefied hematoma that helps you to define some of the surrounding brain. The brain is not so edematous as in the hyperacute phase. And the fact that you have waited a few weeks, also it helps you to better define the boundaries of the nidus, which again, in the presence of a hemorrhage, often the nidus can be relatively split by the hemorrhage itself. I know that there
Another,
are surgeons that feel, well, if the patient has had a bleed and there's some neurological compromise, why not operate in the acute phase? Well, we have to be careful because the vast majority of patients I've seen with the bleeding from an AVM, as often if you wait long enough, and those patients, they often tend to recover. So a patient that has a persistent deficit from operation after a fresh bleed from an AVM, I think always in the back of our mind, we should question ourselves whether or not the surgery itself might have prevented that patient from having the degree of functional recovery that could have had otherwise. So I'm always a little bit careful not to operate in the immediate phase unless there are, as I said, life-threatening hematoma or those very few situations, usually AVMs with single draining vein where there is outflow obstruction, and I think that there is a high risk of early rebleeding.
another thing, Giuseppe, I like to point out, you had shown one case with some residual nidus. You see, the residual nidus can sometimes be the cause of postoperative bleeding. And that is the very big danger. You know, if you operate for several hours and the patient is all right, and then in the night he has a bleed. So that bleed, more often than not, is due to residual nidus. So what one has to do is, if one has to be absolutely sure that you are not leaving residual nidus behind. And my understanding about AVM surgery is when the small vessels, if they are keeping on bleeding and you are struggling to get control of them, that is the indicator that some residual thing is still hanging around the territory. And that has to be, that is one very important thing to resect it completely. If you leave it, earlier we used to blame this on normal pressure perfusion breakthrough and all those kind of things. But more often than not, this residual thing is the more important cause of postoperative bleeding. And we have to be absolutely, absolutely sure that we do not leave residual AVM behind. I think that is very important message that you gave, Giuseppe.
Yeah, I think the after the resection, one of the critical aspects of the surgery, and again, that psychological preparation plays a role there. You need to resist the temptation. At that point, the temptation is to often leave the field to your assistant and go and take a rest, and you feel we are done. No, one of the most important parts of this operation is that once the AVM is out, it's to really carefully inspect the cavity, and sometimes it's difficult to tell because the surrounding brain can be a little bit confused and might not be so clear whether or not there could be residual nidus, or in the surrounding brain hopefully is very friable because of all the sudden the AVM has been removed, and the brain that around the AVM that was in a situation of relative ischemia because the AVM was stealing blood, then it's exposed to normal blood. In terms of blood flow, in terms of the postoperative bleeding, I think that the postoperative bleeding is probably multifactorial. Definitely unrecognized residual nidus, especially in absence of a channel of egress, in absence of a draining vein. If you don't have shunting, definitely that's a part of it. Another part is that the thrombosis of the draining vein might extend to involve normal veins and therefore cause a venous infarct around the territory of around the cavity of the AVM. Or other times, I think could also be related to unrecognized intraoperative bleeding that becomes only clinical evident after a few hours following the resection. So there is no question. I always tell my residents after an AVM, and everybody feels good about, I always tell the anecdote of a very, very famous colleague, great AVM surgeon, who supposedly decided to quit neurosurgery after a brilliant career the night that he received a call that one of his AVM patient had bled during the night. So there is no question that especially that night, first night after the operation, it's really, if the phone goes off, then it's usually bad news.
Another, Giuseppe, another smallish point before you go further. Sometimes we take a decision like in eloquent area, motor strip region, and eloquent area in general, and you have a bleed, and the person has come hemiplegic to you. You know what? This hemiplegia will certainly recover in 2 months, 3 months, as you mentioned that they recover. And then you operate on a patient who has recovered from hemiplegia. Now, the problem is if he has recovered from hemiplegia and you are operating and he becomes hemiplegic after the operation, so that becomes a little bit too much of a complication. So in that situation, sometimes I tend to operate in a eloquent area a little bit early when the patient is hemiplegic and I know that he's going to recover, but it gives me some kind of an insurance or some kind of a safety zone that, otherwise to make a normal person hemiplegic after surgery can be a little dangerous. But if you make a hemiplegic patient remain hemiplegic, then you are not so much blamed. So nowadays, what sometimes in motor area, AVM in particular, if I decide to operate, sometimes I decide not to operate because the dangers are too much. But if I decide to operate, I will like to operate in a situation where the blood, in an early bleed, post bleed state. Okay, Giuseppe, please go ahead.
Now, this is another thing that, again, I trained with Dr. Cassell, and like I always say, our mentors are like our parents. You go through training and you work with them, and then only after a few years, once you have been an adult yourself professionally, you realize what they meant. And I remember always Dr. Cassell telling me, say, you see, there is always a feeder under the belly of the main draining vein. And that's absolutely true. Trying to skeletonize that vein and to get across that vein. You can see here, I put a temporary clip. The AVM is excluded, but somehow the vein, it's still red. And the reason is that there are often small feeders and small direct, you can see. I'm trying to coagulate that vein after I put the clip, and there is some bleeding. And then as I, now another trick here, sorry. You see that I have cut the vein, but the vein is still open. Why? Because the AVM, it's almost completely excluded, but if there is still any residual flow, I like that blood to come out from the opening so that I can aspirate, collapse the AVM and go down to the feeder. This is, of course, something that strategy that you can use only once you are absolutely certain that the AVM is disconnected except for that tissue immediately surrounding the draining vein. Here now you can see as we go under the draining vein, we identify, you can see right there, there are small feeders that are coming from deep, and they were going directly into the draining vein. So it becomes very important. What I've learned is that if you can, and you are in an area where you can do, it's always better to skeletonize the short segment of the draining vein past the AVM and inspect that segment very carefully, because they can be direct small AV shunts going directly into the draining vein. And this becomes particularly important in children that have what people have defined as linear type AVM. Basically, it's almost an AVM, developing AVM, where you have a skeleton formed by the draining vein, and you have these small, tiny feeders and a very irregular nidus all around this main draining vein. In those situations have been where in eloquent area, I didn't skeletonize the draining vein enough, and I end up leaving a small residual which required reintervention. Now, I'm done with some of the practical surgical tips, and now I like to discuss a few things, including the role of embolization. First of all, I like to clarify that AVMs are not congenital. And this is important for the young colleagues. Dr. Goel was talking before about academic neurosurgery. It's important for the young colleagues to challenge current knowledge, because the knowledge in 50 years will be dramatically different. And when I start looking into the issue of congenital AVM, I say, where this came from? Well, it came from the fact that you can see AVMs in little children as young as 2 years. It turns out that AVMs during the first year of life are extremely uncommon. If you exclude the vein of Galen AVMs that we know are not true AVMs, it's a misnomer, number one. So AVMs, they tend to occur with the increasing age, and although they can be seen in children, they are exceptionally rare in the first year of life. Number two, we know if you look at one of the ultrasounds in utero ultrasounds that they are able to do nowadays, you get a beautiful depiction of all the structures. And as far as the brain, almost you can get an MRI of the brain. And yet, I am aware of only maybe one true parenchymal AVM that was diagnosed in utero. Nowadays, if a fetus has one of those large AVMs, you will be able to see it on the ultrasound the way you see a vein of Galen AVM. And number three, now, since everybody gets an MRI, there are many very well documented cases. We reported two here with one of my fellows, Carlo Bortolotti and Saul Morales, and we collected the literature, and there are several very well documented cases of patients that had the study, including an angiogram, and there was no AVM. And then years later, they went on to develop an AVM. So AVMs are not congenital, and yet, if you take most neurosurgical textbook, you read that AVMs are congenital lesions, which is, of course, not true. This is a case, a patient that had an MRI because of she drinks too much, and she has alcoholic encephalopathy. That's the reason for this MRI in 2007. 4 years later, she comes back and she has a small bleed from an AVM. The other thing is that AVMs are dynamic lesions, especially in children. We know about the issue of recurrence in children. This is a patient who had an MRI in 2006, a small abnormal vascularity here. This is 10 years later. Now there is a frank, well-developed AVM. So they're not congenital, and they indeed, especially in younger people, are dynamic lesion. Here is the issue of embolization. As Professor Goel said, I have training and I also do endovascular procedures. And actually, I am a very strong proponent of endovascular therapy, especially for aneurysms. But it turns out AVMs is one of those problems where I'm very careful about embolization. Why? Because like anything we do, embolization, surgery, or gamma knife, or even medical management alone, there are complications. So when we suggest a so-called multidisciplinary or multimodality therapy, it's always very important to be careful about the potential. Every procedure adds complications. And actually, when it turns in my hands, then a complication is mine when it happens at surgery, when it happens from embolization, or if the patient bleeds because I decided not to do anything. So maybe that's the reason why I am particularly careful. So what is the role of embolization? I have no question, there is no question in my mind that with the modern liquid embolic agents, you can treat, you can cure an AVM, even a complex AVM. But I've been in different labs around the world because I want to be sure what was possible to do with embolization. I've been in many live courses, and I can tell you one thing, that when you try to embolize an AVM for cure, you always take a chance. And I don't like to take chance. In other words, when you go for cure with the embolization of an AVM, there is always a moment, always a phase where there is a certain degree of randomness that honestly I don't like. And that's the reason why, and it turns out that those AVMs that can be cured with embolization are also the ones that are easier to cure with surgery, are also the ones that are easy to cure with gamma knife. So I personally, it's not that I don't believe in embolization as a cure. I do not practice and recommend myself because it tends to be to have a complication rate that is higher than surgery or gamma knife in the properly selected patient. So that's about embolization as a cure. Now, what about embolization as adjuvant therapy in preparation for surgery? We say, well, embolization can be very helpful because with embolization, you can embolize feeders that are deep, and they are usually the ones that are the ones that you find late at surgery. Well, that's true, but it's also true, at least in my hands, that embolization of deep feeding vessel has a complication rate that is higher than embolization of superficial feeders. So yes, it is a valid strategy to embolize those deep feeders, but you have to balance that with the risks. There is no question that there are certain situations, especially for those parietal AVMs that take from MCA, ACA, PCA, where you can often embolize the PCA feeders that come from below, because those are the ones that you are likely to encounter late in your phase, while it's much easier to isolate superficial MCA and ACA feeders. So there are situations where I think it's helpful, but again, I caution because every time we use an adjuvant therapy, we always introduce the risk of additional potential complications. The other issue of embolization as pre-surgical therapy, and I've used for that specific reason in the past, is that when you have high flow AVMs, it is, in theory, it might help to try to slow down the flow with embolization before surgery so that you can do in a more gradual fashion. In those cases, I bring the patient for one embolization about 10 days before the surgery and take a pedicle. Then after a few days, we'll take another one, and then we follow with surgery. So there, the idea is to progressively decrease the flow to the AVM so that in a way you quote unquote prepare the surrounding brain for the sudden derangement in flow dynamics that you might induce with the surgical resection of the AVM. But again, I don't have any way to demonstrate that it's helpful. It's theoretical, but the way it's done for that specific purpose, since you take the feeder proximal to the nidus without going into the nidus, without compromising the venous return, it's relatively safe. This is another topic that we have been very interested in.
Giuseppe, before you go on this, I will like to clarify my own self. And I want to know, as an adjuvant treatment for AVM surgery, are you convinced that it is necessary or not? Say,
no, I don't think it's necessary. I don't think it's
that
necessary.
Is very important,
because
when it comes from you.
Because, as I said, that the superficial feeders, with the experience, and if with a little bit of aid from the ICG fluorescence, you are able to identify yourself early during the surgery. The deep feeders, there is no question, they are late, they are challenging to control, but the problem is that too often, except if they are posterior cerebral artery cortical feeders, all the other deep feeders, to embolize those feeders, you can do it, but it comes with the risk to the patient. So I don't see a strong need. So I don't think it's necessary. And we have to be very careful, as I said, every time we add another procedure, because every procedure we do has the risk for complications.
So that is a very, very, I consider it a very important thing, because it is coming from a person who is also an expert in endovascular and also in surgery. See, my personal take on AVM's surgery is I do not think preoperative embolization is necessary when I am going to operate. So the question is, if I say that no, this AVM is too much for surgery, or maybe it is not suitable for surgery, in that case, what my strategy is, and I would like to question you, if the AVM is in a little bit critical area, and I think surgery is not possible. So, do you think there is some role in embolizing some intranidal aneurysms or some kind of, little bit embolization because we are not operating in any case? Do you think there is some role or no?
Yes, I think there is definitely a role. For example, if you have feeding pedicle arterial aneurysms, there is no question that in an AVM, the presence of feeding pedicle aneurysms increase the risk of bleeding over time. So those aneurysms, they can be treated with any standard endovascular therapy that we apply to aneurysms. So that's yes. As far as the issue of intranidal aneurysms or in unruptured AVMs, I'm not sure that targeting certain portions of the AVMs because there might be some intranidal aneurysms might, if it indeed that helps in the overall scheme of things. There is no question, and I will show a case that in the acute setting, embolizing, if the AVM is very complex or embolize or don't want to operate right away, embolizing the portion of the AVM that is bearing a intranidal aneurysm, or if you can identify nowadays with CTA, you can usually identify the site of rupture. There is no question in those situations, embolization has a role, and I will show you a case about that. Now,
Okay.
the issue about large AVMs, let's embolize the AVMs, reduce the nidus so that the AVM then can be treated with radiosurgery. We have a very active radiosurgery program here, and Bruce Pollock and Mike Link do the bulk of the radiosurgery for AVM. They are really careful in their selection, but we do not believe in the fact that embolization helps with radiosurgery, because if you really dissect out the literature, you cannot really find convincing evidence to support this strategy. And again, every time you add, we're talking usually of complex AVMs, every time you add a procedure, there are additional risks. And also there is some literature which might suggest that maybe pre-radiosurgery embolizations might make the radiosurgery planning more difficult, might obscure portions of the nidus, or might even interfere with radiosurgery. So we don't subscribe to this strategy because we don't think that there is very strong evidence to support. What I would say, though, that for complex large AVMs, especially in young people, and there is not an age cutoff, but my anecdotal observation is that if a patient is younger than 30, they do respond quite well to gamma knife. So for large complex AVMs, we have been doing more and more staged gamma knife that seems to be fairly effective. And then remember, if it's not 100% effective in reducing, in obliterating the AVM, then you always have the option of doing surgery on a much smaller AVM after radiosurgery in a situation, as I showed a case before, where the surrounding brain is gliotic and the surgery becomes easier. I discussed about curative embolization, and now I will show a case where what I would consider palliative embolization, that is like you take care of the dangerous part of the AVM, what we were discussing before with Professor Goel. This is a 70-year-old lady, has a baseline mild cognitive impairment, comes in and she has this subarachnoid hemorrhage. The subarachnoid hemorrhage is from this dysplastic superior cerebellar aneurysms along a pedicle to this deep AVM. In this situation, you can see the superselective catheterization. You can see the dysplastic aneurysms. These were glued. So this is the pre, this is the post. The aneurysms have been excluded. The site of bleeding has been controlled. Here you can see on the CT scan the glue cast, and you have a 70-year-old with some baseline mild dementia, comes in with subarachnoid hemorrhage, complex deep-seated AVM. You treat with embolization the part that has bled, and no other treatment was offered with the great functional outcome. So there is no question that embolization is very important as a role, but at least in my opinion, the role is very selective. Now, I must also say that there are several colleagues that are very skilled surgeons that tell me, and I respect their opinion greatly, they tell me that they found embolization very helpful because they say it will turn a long operation for a complex AVM into an operation that lasts for just a few hours. I respect that, their opinion, and I think that that's a valid there is no question that more complex large AVM, as I said, it can be useful to reduce the flow in a more gradual fashion. But maybe I'm particularly sensitive myself, because if I get a complication, it doesn't matter if it's on the endovascular side, on the surgical side, it's my complication anyhow. I am very cautious, and I would rather spend a few extra hours at surgery rather than taking any chance with routine embolization. But that's just my feeling.
Another smallish question, Giuseppe, for you before you go to cerebellar AVMs. What do you think about partial embolization? Do you think, yeah, of course, you are saying that it is not suitable for, very helpful for radiosurgery. Whether partial embolization of a largish AVM, what do you think is the long-term difference in the bleed rate, in the symptom rate, in the convulsion rate, in the headache rate, partial embolization? What is your take on this?
I think that partial embolization, if we look at bleeding risk, there is really, I don't think there is good evidence to suggest that partial embolization protects against the long-term bleeding risk. Partial embolization has a role, though. If you take some of those hollow hemispheric AVMs, patient has intractable seizure, surgery is an option. Gamma knife, it's too large for gamma knife. Partial embolization in those patients try to target the highest flow areas to decrease the ischemia of the surrounding brain in patients with intractable seizures, or those rare patients that have true symptoms of still from the AVM. I think there is a role there as a palliative measure. The issue with partial embolization, though, is that like you might think, okay, if you have an AVM, it's like a river, right? If the river is full, it's more likely to flood. But if you can reduce that river to 40% of normal capacity, then it's less likely to flood. So there could be a theoretical reason to try to decrease the flow of a very large AVM, in theory, to reduce the long-term risk of bleeding. The problem is that the AVM is a low-pressure shunt, and unless you act on the nidus, the AVM will start sucking blood from the surrounding brain, and some of the nightmare AVMs that I operated were AVMs that had been partially embolized years before, and now the AVM is being fed by a tiny little network of adjacent vessels, and it becomes very difficult to navigate what's AVM, what's not AVM. So the partial embolization in an AVM also induces, favors supply from collateral vessels, and they can become much an issue. So I think there is a role in selected case like anything else, but it's important also to be very careful in recommending it routinely, because doesn't seem to, we don't have good data to say that protects against future bleeds.
Whilst you are on embolization, just can you make a quick answer to this question, that recently there is a talk about venous route for embolization and handling the venous veins to control the AVM. What is your take on this?
I think that there is no, we know that to kill an AVM, it's like a dural fistula. You need to exclude the drainage of the AVM. Of course, you can do that in a dural fistula because the actual connection, the nidus, is within the two leaflets of dura, so it's like within a carpet. There is no reason, it cannot bleed. Cannot do it with impunity in a parenchymal AVM. What we are doing nowadays with the AVMs, you can almost simulate what we do at surgery, right? You go and catheterize the vein, you catheterize some of the main feeding pedicles, and you can start occluding the feeding pedicles first, and then as you decrease the flow, you can, through a transvenous approach, you can start filling the nidus in a retrograde fashion until then you occlude completely the main draining vein. It works very well in those AVMs that have small AVMs with the single main feeding vessel. But again, cases that I've seen, not my own cases, but cases I've seen done throughout the world by highly skilled operators, there is always that element of chance that you take where you are still working and trying to occlude a vein at the point where the nidus might not be completely excluded. And again, I think it's reasonable to take chances if we have no other options, but when you have options, I don't see any reason to take chances. So that's my take. But definitely it's promising, and I'm glad that there are people that are pushing the envelope in that sense, because it's probable that in the future that might be the treatment for the majority of AVMs, but to recommend as a routine treatment, I am very hesitant because I'm not quite sure about the true incidence of complications. Just a few words about cerebellar AVMs is another topic where I've learned a lot from my friend Evandro de Oliveira, and it's basically I've learned that cerebellar AVMs can look daunting, like in this case, but as Evandro has shown us, as long as the AVM is away from the cerebellar peduncle and it's not getting, it doesn't involve the dentate nuclei, you can remove AVMs like this that are hemispheric AVMs. It's possible, it's doable. They are of course challenging, but not quite as challenging as you might expect from the angiographic appearance. And this is the patient, same patient 1 week later when he came for suture removal with my nurse at that time. Just a few words about a subset of AVMs that can present with venous varices and edema. This is a lady, 58-year-old, with progressive leg paresis and the left arm weakness that was getting progressively worse. You can see that she has a AVM in eloquent area with a lot of edema and venous varices. Now, I'm interested in Professor Goel's view about this. If I would have seen this patient without the edema And without the progressive neurological deficits, I wouldn't have considered surgery fairly risky procedure. And I must confess that when it comes to AVMs, and again, I don't know if it's a psychological component, it's, yes, we can use and we can discuss about all the different classification schemes that have been proposed, but I often find myself operating on patients like this lady out of necessity, only to realize that the surgery was not quite as daunting as I would have expected otherwise. And again, I'm not sure if it's because of in a patient like this, psychologically, you are prepared. First of all, she has progressive deficit. So if you don't do anything, more likely she's going to get worse. Second of all, the patient is more likely to accept the risk of the operation because she has seen herself getting worse over time. And third of all, you go in with the idea that the patient has already some deficits. So as Professor Goel mentioned before, you don't feel quite as guilty if the patient comes out of the operation with a deficit because the deficit was there before. And after a surgery like this, I often question, I say, wow, I mean, the surgery was not quite as difficult as I would have expected, and it will show this patient made a decent recovery. So this is to stress again that definitely the decision making for AVMs is still one of the most critical part, and at times it's really the most difficult portion of the entire process. This is the late phase of the lateral angiogram to show the large venous varices indicating a venous outflow obstruction. This is the AP, and this is the pre and the post-op MRI. And these are the angiograms. So we did surgery, and this is the lady. You can see that she has a component of spastic hemiparesis on the left side, but you can see she's able to, this is 3 months later, she's able to ambulate without any assistance. And more importantly, you will see when you look at her fine end function, it's actually fairly good. So again, this is to number one, to show that there is a subset of AVMs that can present with edema, and these are usually related to venous varices, venous outflow obstruction. It's a relatively unstable situation. And number two, always very difficult to decide, especially in the patient that has no deficit, what to do, and the decision making. And even after having operated on over 100, with probably 150 AVMs, still it's very difficult for me to, in a complex AVM, to identify that patient where I can confidently say that surgery is the best opinion and that can be done with the very low risk. Well, once again, thank you for giving me this opportunity. It's been a pleasure. I'm happy to answer any question. As I said, I wanted primarily to focus on some very simple principles with the younger colleagues in mind, and a lot of those things that I wish would have been stressed to me early on. And it's not that they were not stressed, it's just that as you have not operated AVMs by yourself during your training, your mind is not prepared to understand the profound significance of some of the statements that we hear from our mentors, or that we might find here and there in a book sentence.
Okay, Giuseppe, that was fantastic. I'm sure many young people and many senior people You see, there is no young and senior when you're dealing with a subject like AVM. You see, you have to be absolutely fantastic to be able to handle AVM. So AVM surgery is a terminal part of your understanding the philosophical issues about surgery, understanding about your own capabilities, whether you will be able to actually operate or you are not able to operate, and whether you can operate. Those are the things, whether you will be able to come out clean, whether you will be able to control the bleeding, whether you will be able to control and dissect and completely remove the AVM. You see, because the problem in this AVM is the complication. Suppose you are operating an AVM for headache. Giuseppe, can you unshare your screen? Let me show some few slides. I didn't want to present, but because you have, I
Atul,
have.
there is a question. Maybe we should answer before we go
Yes,
for
yes,
it's.
yes, yes.
What is the recommendation for AVMs with the predominant nidus in the ventricles with the deep venous drainage? My
Yes.
answer is that if the AVM is in the lateral ventricle, then it's and it's primarily in the ventricle, then surgery can be a very reasonable option. Usually these AVMs are fairly very well confined, and they usually are smaller in size. If there is involvement, it's not only the ventricle, but there is involvement of highly eloquent areas like the thalamus or worse, the hypothalamus, then of course everything becomes a little bit different.
Yeah, okay, Giuseppe, unshare your screen. Let me show some
Okay.
slides. I was not preparing to present, but let me show a few slides and I will ask you some questions.
For some reason, it's not.
No, in the top.
Yeah, no, I know, but it doesn't let me.
Yes, now it is.
Okay, now okay.
Okay, Giuseppe, here is the patient, a young farmer, and he has the only symptom of headache. And you see, I am not showing the complete angiography.
Can you show? Are you sharing your screen? Because we cannot.
Yes.
We can see you, but we cannot see your screen.
You cannot see my screen? Wait. Now you can see my screen, Giuseppe? No?
I can see you. I cannot see your screen. I don't know why.
We can see your screen, Atul.
I think, Giuseppe, you cannot see the screen because, I can now. No, Giuseppe?
No.
So that is a little bit unfortunate. So I don't know how to do it now.
He can log in and log out, log in and log back in, log out and log back in. Then it should be okay.
Log out and log back in, Giuseppe. Are you doing that?
Yeah, I'm trying.
In the meantime, I'll ask the participants to see this angiography. And you see this is a young man about 20 years ago, 20 years old, farmer by occupation, comes from a village, and he has the only symptom of headache. Now the question is whether you will like to operate for headache. The question is that you know that it is going to bleed very furiously and you can have a big deficit. For headache, you cannot create hemiplegia. For headache, you cannot create unconsciousness. So if you are going to operate on this person, you have to be 100% and absolutely sure that you will come out without a deficit. I'm not saying that you will always come out without a deficit, but you have to be reasonably sure that you will not create a big disaster. So I had said that no operation for this gentleman, but after a few months he comes back and tells me, no, you have to operate because my headache is too much. And this I had done several years ago. And you will see that this is the preoperative angiography is not so good. And this is postoperative image. And this is the boy. And you can create, you can give absolutely symptom free life to this man if you can operate. The question is whether you can operate. The question is whether you want to take the risk. Now, another similar case. I have shown these slides on several occasions, but for few who have not seen, please see this. Now, this is the young girl. You can see her holding her head. And this is the huge AVM. And you see this is the 3D model of the AVM. And headache and young girl. Now, what is your decision? Giuseppe, are you with me?
Yeah, I unfortunately I cannot see your screen. I'm
Oh,
trying to change my view, but the system keeps crashing. But in any case, I can say that if in a patient with the headache, first of all, I try to understand the where the what is the source of the headache. And it's not uncommon, especially if the headache is localized to the side of the AVM, that the headache is often related to contact of large draining veins with the dura. So that could be potentially, if I feel that the risk of surgery is too high, that could be potentially an indication for partial embolization to decrease the flow and in turn soften the large draining veins. And it's definitely a strategy that we have used in the past with some degree of success. Sometimes you deal with patients that have refractory headaches, and it's almost a life-threatening situation because they can be so affected, they can be suicidal. In that case, then I think it's worthwhile taking a risk. And as I said before, it has been not unusual for me in those situations where in a way I was pushed to operate, then to realize that AVMs that seemed to be quite challenging and daunting were actually possible. So I think it all comes down to a risk benefits ratio. And we always, in those situations, if surgery is not, especially non-ruptured AVM, so the issue is not so much bleeding risk, but it's more improvement of symptoms. Then in that situation, if there is a partial embolization option, I would consider. If the AVM is large but amenable to staged gamma knife, especially in a younger person, would be another option. And there are situations, I've been there before, where I was pushed to do surgery because the symptoms were so severe that were almost disabling, and I felt justified. But unfortunately, I cannot see your screen.
no,
But
you
that
log
that
out
would
and
that
come in because it is important. Giuseppe, I want to take your opinion and I want to show some cases. You log out and log in. Okay. So this is the large AVM and this is the girl. You see, she's holding her head and her hair here and hair there. And then, of course, you can see this patient has been operated and this patient has got a smile back. The issue is, you see, in these kind of cases, you can cure the person and you have cured this girl. So, but the bottom line is you have to know whether you will be able to actually, you see, such a large AVM and feeders here. But you must know that all AVMs have some weak points and some strong points. So if you know that the whole AVM is being supplied by anterior cerebral artery from this point and how this is, where it is located and all those things, if you know, you see, this is the AVM you come here and you come here. So you get to the weak points and get to the feeders and then learn how to control the bleeding. I think we can cure these kind of people and restore the smile of these people. Now this
No,
patient, Giuseppe, are you with me? You can see the slides now? No?
Yeah, I can see the slides. Can you hear me?
Yeah, I can hear you. Now this is another patient I had done some time ago, some years ago. And this patient had come, this is about a middle-aged lady, and the only symptom was giddiness. But the giddiness was just too much. Now, in this situation with this kind of AVM, a person who is alive, kicking, working, jumping, making food in the house, working at home, and complaining of giddiness, which everybody complains. Now, whether you will like to take the risk in this patient. But you know what? In this patient, there are some very nice points. One is there is a large anterior cerebral artery and focal feeder. So you can get to this artery quite early in the operation. And then there is a large PCA feeder. So these two, PCA intrahemispheric, you can come and get this feeder, PCA you can get, and then of course this is a difficult thing, and maybe if this lady comes to me today, I may say no operation or whatever, but this was resected, and this patient is, I had done some 10 years ago, and this lady recently came, she's absolutely fine. So these are the trophies that you get. These are difficult situations, but there are some weak points and nice points for surgery, and surgery is a possible option. This is another case right in the speech area, right in the motor area, and the only issue is convulsions. That is the issue. Now, you operate, you may not be able to cure convulsions. They will still be there. And if you operate, you can create hemiplegia and aphasia. So whether you will like to operate this, Giuseppe, what is your take on this?
Well, this one is the patient is having seizures, has noted the bleed. This is one of those that I would consider gamma knife.
I think if she
Since
comes
the
to me
volume,
today,
it's borderline, but I think it's doable.
So this was resected at that time, and the convulsions are completely controlled for several years. But if she comes to me today, I am not sure whether I will have the guts to remove this, because this is quite a formidable AVM. But I did 10 years ago when I was a little bit more enthusiastic, and I removed this. This is another huge bag of worms. I call it bag of worms. And the only issue was convulsions, and also quite furious convulsions. Means he would shake up the whole room, and he will just shake up everybody. And this is the large AVM. Of course, this is not an easy AVM. This is like quite an AVM, and this was resected, and this was resected. Now this is another AVM and has come with bleed. What is your take, Giuseppe, on this?
Well, this is again an AVM I would consider quite challenging to remove surgically. Without potential. Depends also what kind of deficit the patient has baseline, but. The fact that there is a hemorrhage, then patient has said the hemorrhage changes a little bit, shifts also your willingness to take risks. So I would there are no, I think that embolization and surgery could be potentially an option in this case. I will have to look a little bit more carefully on the exact distribution of the AVM, but the bleeding and the fact that there might not be adequate other options in this person, then might make surgery. In this case, I would definitely use preoperative embolization to help take care of some of the feeders before going into the AVM. Well, the other thing with embolization to say, and this that it facilitates, one of the challenging parts of AVM surgery, especially in this particular AVM as you get close to the deep structures. The preoperative embolization, it helps differentiating feeders to the AVM, because quite often when you operate on an AVM that has previously embolized, you often are there thinking, wow, I would never have taken that particular feeder. And here you can see that the embolization material has closed that feeder, and often without any sequelae, because the normal brain has a lot of collateral potential supply in a patient where the blood is stolen from the AVM. So in this situation, to summarize, because of the bleeding, of course, your risk profile has changed, and I will look very carefully at all aspects of the AVM. This is an AVM that I would avoid operating in an acute phase. So I would put an EVD, let the patient cool, and then look at the options.
Yeah, I agree with you. You know, these kind of AVMs can be quite dangerous. But you know what? Even in this AVM, there are some nice surgical issues. One is the large PCA that you are seeing here. When there is a large PCA, you can get to this area quite beautifully if you know how to get to the PCA early in the operation by interhemispheric. That is one very important surgical tip for these kind of AVMs where there is a huge PCA. And also this AVM is quite low down near the tentorium. And I have a feeling that these good points can help you during surgery. And of course, this was removed. This is preoperative, this is postoperative, and this was removed. Now let me show you another one. This is also quite an AVM in the velum interpositum near the vein of Galen. But you see the good points in this one is one large anterior cerebral artery. So when you come from the interhemispheric fissure, you can get this artery. The other thing, that good thing is there is a large PCA. So both these things combined were good. You know, also I had operated several years ago this case, and this was removed beautifully, as you can see. So these are the successes which you take with you through your life, and you like to show your successes, but obviously there can be issues which may not be your trophies, they may be your disasters. So this is another trophy of mine. This guy was a mathematics teacher in central India, and he had been embolized several times, but he was continuing to have very severe headaches. At that time, you see, when I was young, and this was done about 20 years ago, and this was resected using many clips. You see, many clips are here. And this guy is still doing quite good mathematics and working. So if you are able to cure these people, otherwise, imagine he was having such severe headache, he would be considering suicide as an option. Now, if you have cured and he's teaching mathematics, you have given a life. On the other hand, you could have created a big disaster. That is another thing. Now, this is one AVM which was embolized earlier. Now, whether preoperative embolization helps or not, the answer Dr. Giuseppe has already given us, that it is a question, it is a questionable issue. And if you really ask me, I work in a department where embolization is done quite often. And we have a large interventional radiology department. But I don't really think embolization helps me during operation of this kind, and this was done by surgery. But this is another AVM now. Giuseppe, what do you think you will do then? This patient is having quite number of convulsions. And I will tell you, this is one disaster. This is not a trophy for me, but a disastrous trophy. Now, what do you think can be done for this? This is right quite in a difficult area, in the motor area. And you know, this was referred by a very prominent person of the country. From Union Health Minister, this referral had come that, you know, they wanted me to operate. And because it was referred from Union Health Minister, I jumped on it. And whether I did a right thing or wrong, that is the question. Now, this patient is in quite a high flow AVM and in the motor area, and I removed it. And a good, nice thing to show. But this patient developed aphasia and hemiplegia after surgery, and quite a dense hemiplegia and quite severe aphasia. But he recovered quite a bit over the years. But he's still quite hemiparetic gait. He can talk also now. He understands everything. Now, whether I should have done it or not, what is your take on this, Giuseppe?
Well, again, this is, I think it's an AVM where, because of location and size, that if you do surgery, you are more likely to cause a deficit. So this situation I would have avoided as much as possible. And then if the problem is, you said this was having seizures,
Yeah, only
you know,
seizures.
yeah,
But quite a number of seizures.
trying to seek alternative options. I'm not sure if I think potentially gamma knife in the staged fashion would have been an option, and there is good evidence to suggest that gamma knife it's helpful in reducing seizure frequency in patients with AVMs and seizure. So because of the location, in this case, that the risk of ending up with the permanent deficit after surgery is fairly high. I would have looked for alternatives.
So my message, and the message is quite loud and quite clear, that you have to really understand these AVMs. You have to know when to operate. You have to know when to avoid surgery, and you have to, here is the actually surgery. It was quite clean and quite beautiful, but it was not, the outcome was not as good as was, as would have been, expected. So the only thing I want to give a message in this case is that just because the patient was a high profile person, that just does not give me an indication to surgery. Just because the relatives are agreeing to operation, that does not give me an indication for surgery. Just because everybody is ready and I want to operate, that is not a good indication for surgery. We have to see various issues, when to operate, whether to see. This AVM had several good points for me. You see, large anterior cerebral arteries, which could have got, and I removed this AVM beautifully. If you see this video, you will have several nice things, but I don't want to, because this is Giuseppe's show today. I don't want to take away that, Giuseppe's thing. But this is another AVM which patient had come with a bleed, as you can see here. And this is quite a, with large aneurysmal dilatation in the AVM, and a little bit tricky site, but this was removed quite beautifully. And here is just let me show you a few things here. And this was removed with quite a fantastic removal and quite a fantastic result. I must say that, if your planning is perfect and your execution is more than perfect, your bleeding handling is absolutely perfect, more often than not, you will give a beautiful outcome. So, also the young people, if a message can be given, that of course here I am showing large and difficult and dangerous AVMs, but many of the AVMs are not as dangerous looking or dangerous as you are seeing here. This was ultimately resected and dissected circumferentially and removed. So here is the post-operative angiogram, and this is the AVM, which has been successfully removed without any deficit or without any problem. So my feeling is AVM is quite a resectable story and quite a surgical issue, and we should not be, too, we should not take them, have a negative view about it. Surgery is a very positive thing, and surgery is a completely curative and probably the only curative form of treatment for AVM. The bottom line is that we should know when to operate. Bottom line is that we should know when we cannot operate. And the ultimate thing is, if we are operating, we should have that great confidence and great technical expertise to come out successfully. So I will ask Lucky Tripathi if he wants to ask some question. Lucky. So he is not on the screen, but Giuseppe, you want to say final few words before we wrap up this show on AVM? As you can imagine, AVM is, there are so many questions yet to be answered, so many lacunae to be filled up. The role of embolization, the role of radiosurgery, the indications of surgery, the performance of surgery, the issues of handling bleeding, which bleeding to handle in which way, large vessel, small vessel, medium vessel, aneurysmal handling, venous handling. There are so many issues. So what do you have to say, Giuseppe? Just summarize the whole show.
Can I
No,
make a comment,
Yeah,
Atul?
just Lucky Tripathi is here. Let him ask few questions before.
Hi, Giuseppe. Nice to see you, Dr. Landino.
Hi, good to see you.
Lovely, lovely talk. I just want to say one thing that, when we talk about any treatment, somebody is an endovascular therapist, he will look at the AVM for embolization. Somebody is a radiosurgeon, he will look at the AVM for radiosurgery. And somebody is a surgeon like Atul Goel, he will look at all AVMs for surgery. And of course, the levels are different, the experience is different. But what you said from your perspective, where you are involved in all the three processes, I had a lot of experience with radiosurgery in Sheffield, with the AVM, especially. We used to do 3 AVMs every day, and also done some AVMs, a very small amount of surgery. And involved, we have a vascular team like yours, very small amount of work. But I really liked your philosophy and the very fine points you showed, both technique of the surgery, the limitations of embolization, and the advantage of radiosurgery. Thank you very much, Dr. Lanjit.
So Giuseppe,
Thanks.
in today's lecture, Juha Nemi was observing your lecture. Dr. Hongo from Japan was there. Dr. Victor Perez from Mexico was there, and there were several other colleagues on watching the presentation, and obviously have their opinion and have their various recommendations. But I'm sure that your presentation and your work and your lecture will go far and wide and deep and will stimulate young people to operate on these difficult lesions. Giuseppe, your comments, and then we wrap up the show.
Well, I thank you for very much. It's been a lot of fun to share opinions. It's definitely a very challenging topic. I think it's very important to have options. But like anything else, when you have options, then deciding how to use those different options and which patient then often becomes one of the most challenging part of the entire procedure. I do agree that surgery has an important role, but I also know very well that having embolization and having gamma knife available as options really allows us to treat, I would say, effectively and safely the vast majority of these patients. So it's always important to keep an open mind and try as much as possible to make the right decision and let any other consideration, leave any other consideration apart. And what I've learned is, like anything else, surgery is a process. And I remember Vinko Dolens talking about aneurysm crippling, and he said, it's a process. Once you know the steps and you follow those steps very carefully, then you can be successful. But it's very important to know and to respect every single aspect of that process.
So with those words, I have great honor and pleasure to thank my dear friend Giuseppe. And there are, this was live relayed by Neurosurgical TV. It is on YouTube, on Facebook, Twitter. So there is wide and deep circulation of this presentation, and wonderful presentation, wonderful teaching, and wonderful learning for all of us. Thank you, Giuseppe, for your
Thank you.
participation and your presentation.
Thanks.
Bye-bye. Bye-bye, Giuseppe.
Thank you. Bye-bye. Atul.
Bye-bye. Bye-bye, Lucky. Abida, bye-bye.
Bye.